also one case. I will share some basic information here. A 34-year-old male whose job is a window cleaner fell. Was about 4 or 5 meters height. Luckily, this was an isolated injury, presented with back pain, no motor deficits, but mild leg pain and radicular symptoms, basically paresthesia of pins and needles in the anterior thigh to the knee, so about L3. And you can see there I don't have all the series, but we have the sagittal and axial scans. And my question to discuss is whether someone would go for no treatment, or posterior only, or anterior only, or posterior plus anterior. I don't know how we're going to do this because we don't have a polling system, but I guess we can ask the panelists first.
Thanks, Andreas, for this very common case.
Yes.
I think there are a few things to consider. One, of course, is the severe compression of I would say the cauda disease at the lumbar level. The second point is the complete blowout of the vertebra with multi-fragment fracture appearance. There is not that much deformity there, but there is a loss of height, of course, of the vertebral body. So I would personally treat it by immediate, urgent posterior fixation. I would go to one level above, one level below with monoaxial or USS chance screws in order to restore the eye, to try to obtain some sort of ligament ataxy and to obtain indirect decompression. And then I would look at the vertebral body after the first surgery, and to check about the persistence of this line of fractures, but potentially the disc space has interposed into them, and the McCormack is quite elevated here, so I would probably be in favor to restore the anterior column by MIS corpectomy. And but again, in these cases, we'd also rely on the postoperative CT scan to see how the vertebra shape is, and if we could restore a good contact in between the bone fragments. But most of these cases we do treat by posterior percutaneous plus MIS corpectomy in a stage of the procedure.
Thank you, Enrico. Would you do a decompression at this stage?
With only radicular symptoms, knowing that there is no spinal cord at that level, and that there is probably an irritation of the cauda equina, I would only rely on indirect decompression. Of course, there are signs, radiological signs that might probably predict the failure of indirect decompression, which is the rotation of the fragments with an inverted cortical bone towards the vertebral body and not to the nerves. So where probably the ligament, the PLL, is completely disrupted, and probably there is no space for ligament ataxia, or it could be even dangerous to distract the segments. But if there is no potential dangerous sign, I would not do decompression, and with mild leg pain and some radicular symptoms, I would really rely on indirect decompression.
Okay, thank you. Who's next? Lambi?
Well, I couldn't agree more. I would probably, well, I would definitely do posterior fixation, monoaxial screws or polyaxial locking screws to achieve some sort of restoration of the lordosis right there. I think a certain degree of restoration would be possible, but I would definitely do a staged approach. I would also I would do a primary decompression myself. I think this bone fragment, as Professor Torres already said, has probably disrupted the ligament. So I would do posterior decompression also for medical legal reasons, defensive medicine, so to say, and then I would follow the patient up. I would not be very optimistic that this fracture would heal in a way that gives me confidence. So I would predict that in the medium term, it would need also some form of anterior reconstruction as well.
Lambi, if the patient had no leg symptoms, would you be happy not to decompress?
This seems like a spinal canal that gives me jitters. I would probably decompress even in that setting, yes. I have to be honest on this one.
Okay. You can ask, does anyone else want to comment?
Yes. I agree with Lambis. I would go with posterior approach. I would feel more comfortable if, even if it's not necessary. I agree. I would decompress this patient, and I would do a spinal fusions 2 levels above and 2 levels below. I know that it can be done with a shorter fusion because the pedicles in the index vertebra are not fractured, but I think that because of the rotational forces in the area, a longer construct would be safer. And of course, follow up this patient with bracing if later on a second operation will be needed. But in my experience, in most of the times, the posterior approach, even in such severe cases, suffices.
And that's why I love these cases, because whatever you do is acceptable, because we don't know what's best or superior between the different options. I mean, I also would not necessarily bother with the anterior approach. We don't routinely offer corpectomy or vertebrectomy. That's a second or stage, and only if it fails. And I think, to be fair, Enrico, even if we do corpectomy and cage expansion, there is still some anterior height loss in the long run, whatever you do, right? So anyways, so my rationale at the moment over the years I started with 2 and 2, in fact, shortened it. And I don't do a decompression routinely unless there are radicular symptoms. So if there are radicular symptoms, I will do a decompression. But if there aren't, I will rely on ligament ataxis, like Enrico mentioned earlier. And that can be achieved either by intrinsic systems. So the one we have is from a particular company that the screws have a special mechanism within they have a hinge system, so they always go perpendicular to the rod. So they do create some taxis, which is useful. But I think it's fair to say that whatever you do is acceptable, as long as it's within the spectrum of standard treatments. And I think, to be fair, 2 and 2 is still the standard. Yeah. I had also some questions beyond that, because if you want to go from the back, do you do MIS, do you do open, do you do compress, do you not? But it's simply to show the variety of unanswered questions we have, which is great. I'll stop here for another colleague to come.
Great. Andreas, I do have a case. Should I go on?
Yeah,
Yes.
go ahead.
So here the case of 63 years old woman who presented after a 3 meters fall on her buttocks with immediate significant relevant thoracolumbar pain, but neurologically intact. This is the radiological workup with a CT scan, an X-ray, and MRI, showing an L1 fracture, and which we classified according to the house spine being a B2A3, because the MRI showed an involvement of the posterior tension band, and the anterior vertebral body shows a fracture of the upper end plates and preservation of the inferior end plates. So my question to you, how would you treat this fracture of a neurologically intact patient who's 63 years old in your places?
May I?
Yes, please.
Oh, okay. Again, another quite common case that we encounter in our practice very frequently. Well, it's an L1 fracture. She's 63. How is she osteopenic, osteoporotic?
Not known for
Not known.
osteoporotic
Okay.
drugs taken, but
Okay.
I mean, only the CT scan and the X-ray, I would say they don't look that bad.
Mhm. So she has a three-column injury. I think the most rational approach is to stabilize her one level up and one level down without any decompression, and the best way would probably a percutaneous screw fixation with thick screws, at least 6.5 millimeter in diameter.
Would you add any intermediate screw at L1 level?
Probably it's feasible here. Well, we don't have enough images, but yes, but shorter ones, not very long.
Mm-hmm. Andreas?
Thank you, Enrico. Yeah, I agree with both of you. Quite common. We see it every day. I try to, if I do anything, I always try to put an intermediate screw at the index level. In this case, I thought I wouldn't do anything. So my question to you is, how reliable is the P2 classification here? Do we have good views on the MRI, the stereo imaging, that there's a significant disruption, or we're not sure if it's a disruption or not?
So, sorry, I didn't show you all the relevant or bigger images, but on the right side there is an interruption of yellow ligament between TH12 to L1, which is of course visible on other sequences, but for us there was no doubt that there is a ligamentous injury between TH12 and L1. Okay,
well, in that case, if there's a if there's a consensus of a ligamentous injury as well as an anterior injury, then I would probably do one above, one below, one through, no brace, mobilizer immediately. If there is no ligamentous injury, I would simply put her in a brace and mobilizer. So we do like the non-operative approach if there is no significant ligamentous concern. But if there is, of course, things change.
Would you go open or MIS? How do you do it?
MIS, yeah.
Okay, MIS, which means stab incisions or Wilks approach?
Stab incisions, yes.
Okay, so you would do 3 stab incisions each side?
Yes, sometimes they're very close to each other. Let's say, but yes.
Any other options for or comments on this case? Of course, it's a very, very common case, and the first message is that probably in some cases the MRI could be helpful, because probably, as you mentioned, Andreas, without any B2 clear mechanisms, we probably would have treated this conservatively or with a kyphoplasty alone or whatever, bracing. But I think that if there is an important deformity, loss of light, or any indirect sign on CT scan, we should ask for an MRI, helping for the decision. But the reason why I also showed you this, choose this case, is that we did it all in a MIS. First, we do agree this is an unstable fracture requiring stabilization because of the posterior tension band, three columns injury. And there is a kyphotic angulation at the vertebral body, not segmental, but vertebral angulation of the 18 degrees. And there is a lack for anterior support, at least of the superior half of the vertebra. So we did decide to go to surgery and to do this in MIS. And this was our solution, which is MIS fixation one level above and below by Wiltse approach, and respect of the multifidus attached to the midline, reduction maneuvers with chance screws and kyphotic deformity reduction, ligament ataxy, and after having obtained a re-expansion of the vertebral body, anterior support reconstruction with a L1 spine jack. And I do show you how we do usually. We do midline skin incision. You might see here on the right that there is 2 rods of the USS chance screw system. After we did obtain the ligament ataxy, distraction, and kyphotic correction, kyphotic deformity correction. And of course, we did spare the midline and the multifidus, and the plane, as you know, is between the multifidus and the longissimus dorsi. And of course, at the end of surgery, we can reconstruct the fascia layer by layer. And navigation is extremely helpful for the introduction of the trocar for the kyphoplasty, which is done, which is planned with software and artificial intelligence and Braille navigation. And of course, this all you know how we do reduce with chance fracture. We do first the kyphotic, the realignment, and then the distraction. And then this is actually the end results. You see that this is intraoperative images where the realignment is already obtained by the USS system, and lateral to the rods, the balloon, not the balloon, sorry, the spine jack is inserted under navigation, and there are convergent with the PMMA injection, providing a connection between the 2 spine jacks with a cross connection with the cement. And this is the final results. And the patient was discharged very soon after surgery, very quickly after surgery. So thanks a lot. I don't know if there is any comment on it.
Can I quickly ask you something?
Yes.
So I quite agree that the treatment on this one is fairly straightforward. And as my colleagues noted, most of us would probably do the same, more or less the same. My question is, why did you do an MRI in the first place? I mean, obviously, it changed the whole treatment strategy. Obviously, it highlighted things that we wouldn't have seen in the CT. But that was a case where she fell on her buttocks. So I would suspect like a compression mechanism, and then we see a compression fracture. What made you ask for an MRI? Is it something you do standard in those cases?
We do, honestly, we do.
Injury, that's what I'm saying.
Yes, absolutely right. I mean, this is not like a flexion distraction, very clear damage, at least on the CT scan. What actually suggests us to ask for an MRI is the kyphotic deformity of the vertebral body, not the segmentary, the kyphotic, but the vertebral body itself. It was, you cannot see here, there was also slight increase of how do you say it, facet joint space at the level TH12 L1 on the CT scan already, and then very often we do, I would say, for the A3 fracture, we do standing X-ray, which you see in the middle and right, and there was an increase of, believe me, because the quality is not the best, there was an increase of kyphotic deformity by standing. And that's why we suspected posterior tension band and went to the MRI.
Yeah, thank you.
Welcome. I don't know, I stop here. I don't know if you have time for a case. It's already 9.
One more case, okay. One more case, short one.
Okay.
We have time.
Who wanna present? I also have another case, but I don't want to take the...
You can, Andrea?
Okay, I have one more. Well,
go ahead.
Share the screen again. How short? Let's go very short case. Follow nice, 54-year-old female farmer. This is a hint. Scottish farmers are difficult to convince to do anything. Cannot sleep a whole week after the injury. No leg pain, nothing other than back pain. This is the scan. I'm showing you only selected images. Complete disruption, ankylosing spondylitis. You can go through any algorithm. What would you do? Parmenion, what would you do?
All of us are struggling with these cases, that's for sure.
Yes.
And they're becoming more and more frequent. I don't know why, but we have more such cases in the past years. This needs quite a big reconstruction here. At least 2 levels above and 2 below. I would say 3 above, 3 below. And maybe a kind of an osteotomy there to correct the deformity. Otherwise, it won't be easy at all. And I would say an open procedure here with neuromonitoring, of course, even if this is at L2, L1, where is this? Okay.
So very interesting.
An MRI is, sorry, Enrico, an MRI also, I think it's indicated here. Sorry, please.
No, I do agree. This was my comment, because it is quite clear that it is an unstable fracture. Now, of course, he had pain since few days. He walked with this kind of injury, and he was quite lucky not developing a neurological impairment. But I would say there are few points to discuss. First is that there is, of course, a very severe disease, which is the ankylosing spondylitis, which is a stiffening condition of the spine. And very often these are not isolated fractures, and they are very unstable. And so the indication to the MRI in this case is to rule out any epidural hematoma, although he is not neurologically impaired, and to rule out any secondary site of injury. So in most of the cases, we do ask in AS patients, we do ask a whole spine MRI, which is very I would say very easy to obtain in our place. And I would go to surgery then, and I would not position this patient on a Jackson table at all. And yes, we do positioning the patient on a pillow under the belly, in order to try to reduce the hyperextension injury to a more acceptable realignment. So we do position very carefully ventrally on a pillow at the level of the fracture, and then we would go long from the back, 3 above and 3 below.
Yes, well,
yes,
I agree with all of you.
Well, the fracture points, there are at 2 different levels. So is that right? I mean, there is one between L1 and L2, and there is another one at T11, T12. So this makes things even more complicated.
It's a complex fracture, but positioning is crucial. The more intact they are, the more they have to lose, which makes it even more challenging. The truth is, in this case, guys, we planned all that. We planned 3 above, 3 below. We planned neuromonitoring. We planned open because we want to get as much fusion as possible. The patient had walked into hospital a week after this, like this, and refused surgery. He came in for back pain, wanting to some sort of quick fix for the back pain. But farmers here are a particular breed, and they are very hardworking all their life. They never retire, but they often don't listen to medical advice that will put them out of action and away from their work. So this person refused surgery and walked out, never came back. So
no, but I mean, I do agree. I mean, we all are impressed by images, but this is by definition, according to classification, a very unstable fracture. But probably this guy is living well now, or is completely paralyzed. I don't know. But I would say that this kind of hyperextension injuries usually, if they do not agree for surgery. And we do ask them to be seated in bed, not to be laying down, and this is reducing the pain that much by sitting position, sometimes standing. They do realign their spine, and they have much less pain than if they force them to be flat, because we are afraid about neurological impairment. But again, I would really try to convince him to.
Yes, we tried hard.
And as Enrico said before, these patients have very frequently epidural hematomas.
Yeah.
That you encounter just there of a fracture, which may be also the reason of an acute paresis or a paralysis, even with slight maneuvers.
I mean, it's not normal that they walked out, but it's just to show you that nature sometimes has different plans. I don't know the outcome because any attempt at follow-up with telephone, etc., was unsuccessful. But of course, the ideal here is to, whenever we have ankylosing spondylitis, is to fix long segments. That's the ideal.
It's like long bone fractures, isn't it?
Yeah.
And the last case from Professor Tessitore.
Oh, yes. Thanks. Do we have time?
Yes, to conclude.
Conclusion. What is my third case? So 32 years old male. This is a very recent case. It was 2 weeks ago. A victim of a motor vehicle accident. He was hit by a bus while he was skating. And very irrelevant thoracic pain. And he has also a left L4 hypoesthesia together with some pain which was lateral to the thigh and to the hip. But apart from them, the neurological exam was normal. So here the CT scan showing fracture at the level of the spinous process of L4, and on the axial cuts, I would say a good preserved spine alignment, at least at CT scan laying down, and in the middle an increase of facet joint distance between 4 and 5, and on axial, apart from the spinous process fracture, a fracture of the ascending facet of L5, and we did ask for, we did classify with this fracture having B2, N2 because he had the radiculopathy, and fracture without any A component. And we did ask for an MRI because we suspected, of course, the posterior tension band injury, which was already visible at the CT scan, but he also had this L4 impairment on the left side, which was only partial. But we wanted to check about the canal, and this was, of course, an MRI showing that it was a disruption of the spinous process, of course, but the line of fracture went above to the L3, L4 level with an interruption of the supraspinous interspinous ligament, which was actually intact above, and again interspinous L4, L5, and as you might see on the axial, an hyper intense image from inside the canal, the foramen extraforaminal, and the radiologist told us also there is probably an hematoma, which was not an hematoma, but so how would you treat this case? I think I have the solution in the next slide. So I go back to CT scan, B2 injury with neurological impairment L4 left, and this MRI. Who want to comment on it?
So it's a totally posterior injury with a bit of bony and ligamentous and mild radiculopathy. Is there weakness or just pain and tingling?
It's pain and hypoesthesia.
Okay, so no motor deficit. And there is high signal there to explain the left L4 symptoms.
Yes.
I would get an X-ray, an erect X-ray.
Let me check those arrows. The line of fracture or ligamentous injury, and underlined in red. And I have the solution afterwards. So what the X-rays would bring to you, Andreas, in this case?
So I'm not 100% sure that the spinous process and ligamentous injury is causing significant instability. But if I stand them up on an X-ray and it shows some rotational or kyphotic component, then I would stabilize. Otherwise, I would try to use a brace, but with a low threshold of intervention.
Even though you have this kind of facet injury on the right side and increased distance on the left side, the level of the facet joints?
I saw so the facets are still in good, you don't have subluxation of the joint. You do have an intra-articular fracture. However, I get it that it might not, it will be painful but it will heal. That will heal in position. Whereas if he had subluxed, then it wouldn't heal. But the X-ray will tell me whether there is any dynamic instability or not. If in doubt, and if there's any doubt, then okay, then you would have to instrument.
I do not have a preoperative X-ray. Sorry, we did consider this being potentially unstable, and we were a bit worried about having an epidural hematoma and or disc herniation, post-traumatic disc herniation, because on the left you might see that there is a disc prolapse and annular tear. So we didn't perform an X-ray. But I do agree that the standing would probably better demonstrate a B2 mechanism.
Yeah.
comment this one a little bit. I think this is an excellent case because it highlights the very problem we have in translating the classification system into real world action.
Correct.
Because if we rely on our classification systems, this is a B2, all right, there is posterior ligamentous complex injury, and there is intraosseous disruption, there is intraligamental disruption. This is a B2. So if we follow our own classification systems, this is an unstable fracture, and the stability of the posterior ligamentous complex should not be underestimated. At the same time, intuitively, we have an anterior column that is intact, whereas in reality it is not, because there's this disruption right here. All right, so the anterior column is not intact. But what I'm saying is that intuitively we tend to deal with this as an injury that is less severe, as our classification systems say. If we want to be true to our classification systems, this belongs stabilized. And yet intuitively I'm saying that I would also think about going conservatively on this one. I would probably not, because of this hematoma, which turns out to be probably disc material. But this would be my line of thought. It would not be a straightforward process in my mind.
Absolutely right. I mean, and honestly, we were afraid also having an epidural hematoma with a potential increase on sides or whatever, although the images was a bit strange to us, because following this foramen, going along the nerve root, I never seen a epidural hematoma like that. But anyway, to get all together, we did decide to treat it surgically with MIS solution. So we went into the canal. First we put the screws. Okay, this was under navigation. We did use the Viper Prime to stabilize 4-5, which was clearly unstable to us, and 3-4 because of this ligamentous injury above the level of L4, between L3 and L4. And we did find, when we did our Wiltse approach and the midline, an interruption of the supraspinous ligament between L3 and L4. So we were pretty confident that we would also need the posterior tension band reconstruction by MIS screws. And then we went with the tubular retractor into the canal left. We did the arthrectomy, or the partial arthrectomy, and we did find a huge disc herniation, which was actually going into the foramen. And most of the nucleus pulposus was migrated outside the disc, inside the foramen, and we could remove one piece. And then we had a lot of this nucleus pulposus very close to the annular bridge, and the annular bridge was very big. So we were very afraid about having a further problem there. We had already our disc exposed in front of us, and we inserted a oblique PEEK cage, and we did graft the disc. And the patient evolved quite well, in the sense that, of course, apart from postoperative pain, he did recover very quickly for the pain in L4, and at discharge it was still a bit numb at the level of the hip on the left. And I think this is my yes, sorry, my last slide. Thanks a lot.
Good solution. I think it's important that if you're going to do it, and you did address the instability of the ligament that spanned L4, which meant that it affected 3-4 and 4-5. So yes, if you do it, then you have to address all that.
I mean, probably if you would not have seen a disruption of the supraspinous between 3-4, we probably would have limited our surgery to 4-5.
Do you remove the material after some time, or do you leave it in situ for the rest of their lives?
I mean, I'm not confident that this ligament will be repaired. Anyway, I did fuse already 4-5. So I would not remove 4-5 because this will be fused. And I would not remove 3-4 because I'm afraid that this ligament would not heal sufficiently, because this is not only a bone fracture, but again, there's been an interruption of L4 spinous process. This can heal, of course, but I don't know if the ligamentous supraspinous ligament between 3-4 will heal. But ideally, it is possible 1 year afterwards to remove the upper part to regain a bit more mobility. Because he's a young patient, only because of that.
We have a comment from the audience. Any comment from the panel about the ongoing debate on corticosteroid use in acute setting? Thank you in advance. Wow.
Is it still a debate?
I don't think there isn't much of a debate.
Yes.
It has been resolved, yes.
We did abandon in Switzerland, I mean, since many years, we do not apply the NASHIS protocol anymore.
Most of us do the same. Or all of us. It's not a debate anymore, I agree. Well, thank you all very much for the participation, for the very interesting presentations, and I wish you all a very good evening. Good night.
Thank
Thank
you.
you.
Right.
Bye.